My name is Khalil. Admittedly.
Welcome everyone to week 2 of the 2021 summer lecture series. I would also like to specifically welcome everyone on our conference call this evening. We are going to start it tonight with our featured speaker, Dr. Andrew Rosenberg, physical therapist with Grewal Orthopedic and Spine Care. Tonight, he will be presenting directional preference in the treatment of lower back pain. Dr. Rosenberg, would you like to share your screen with us?
Sure. Let me unmute myself. Can everyone hear me?
Yes, thank you.
Okay, hold on. Okay, everyone can see that?
Yes.
Okay, I'm just trying. There we go, perfect. Okay, and how do you guys normally field questions? You kind of wait till the end and then, or we kind of stopping as we go?
We will have a chance for questions after your presentation.
Okay. So first off, thanks for having me. Today we're going to talk about directional preference in the treatment of low back pain. I'm a physical therapist and I am certified in the McKenzie method, also referred to as mechanical diagnosis and therapy. And I work primarily in an outpatient orthopedic setting. So a lot of backs and necks. Tonight we're going to kind of focus, I guess, more on the low back aspect of this. Basically what the McKenzie method is, and just like sort of to summarize, is Robin McKenzie was a brilliant physical therapist in New Zealand back in the 1950s, and he sort of developed this system of assessing and treating orthopedic issues, whether it's predominantly spine, but also extremities as well, right? So we're going to talk a little bit about what directional preference is, and that's pretty much very key to the McKenzie method, to mechanical diagnosis and therapy. A directional preference is basically when a patient's pain levels can improve or worsen, right, with changing and differing active positions, right? A beneficial directional preference would be a repeated or sustained movement that causes a symptomatic and/or mechanical improvement. In simple terms, you find a movement that you're going to move a patient's joints, whether it's a low back, a neck, an elbow, a shoulder, doesn't matter. That's going to make the patient feel better, right? It's going to make their symptoms better. And when we talk about mechanics, mechanical improvement, we're looking at predominantly range of motion, right? It's going to improve their symptoms, their pain, and their range of motion, right? So the McKenzie method identifies the relationship between pain and various aspects of movement associated with directional preference, right? We're always trying to look, is there a direction that I can move this patient's back that's going to make everything feel better, make their pain less, make their range of motion better. We're always sort of looking for that. And basically how it starts, I mean, the first clues to a directional, figuring out, does this patient have a directional preference? Does their back have a direction that it wants to be moved? It really starts out on day one during my initial examination by just listening to the patient, right? The clues are all in the subjective, right? The patient has all of the answers, right? We just have to listen for them. So when I'm listening for a directional preference, getting clues during that subjective exam, the key things for me, the key questions that I find for a patient that's coming in with low back pain are basically, sitting, right? How does sitting affect their symptoms, right? Or and how does standing and walking affect their symptoms? Because if we think about the lower back, what does it do? It basically, it flexes or bends forward, or extends or bends backward, right? There's some rotation in there, sure, there's some side glide or some shearing force, but for the most part, the lower back, your lumbar spine, bends forward and bends backwards, right? So when I'm asking a patient, what effect does sitting have on your symptoms, or prolonged sitting for a long time, I'm really kind of asking, what effect does flexion or bending have on your symptoms? You know, contrary to that, standing and walking, right? Standing and walking, walking is basically repeated mid-range extension for the lumbar spine, for the lower back. So when I'm asking someone, what effect does standing and walking have on your symptoms? I'm basically also asking, what effect does extension have on your lower back pain, right? So I start to get some clues as to, what direction I want to start moving this patient. After my subjective exam, right, after I meet with a patient and I speak with them for the first time, I get a thorough history. I need to get baselines on day one, right? I'm assessing baselines. I'm asking the patient how much pain they're in at that moment, right? What's their baseline pain just sitting there in the treatment room, talking to me, sitting in the chair. Then I'm going to take a look at what their range of motion is. And it's going to look, a lot of these things are going to look similar to that picture on the screen there. I'm going to ask them to bend forward, bend backwards. I'm going to kind of ask them to shear their hips from side to side. I'm going to assess their strength. If it's a back patient, I'm probably looking at their leg strength, their quad strength, their ankle strength. And then if they have leg pain, meaning if it's what we would refer to as like a sciatica, or if they have back pain that's radiating into the legs, I'm probably going to test their sensation in their legs and their feet, as well as their reflexes. And I'm checking all these baselines on day one, session one, so that I have something to compare it to down the road, right? And also something to compare it to later in that session. After I start moving this patient, I want to see, did their pain change? Did their range of motion change? You can even see strength, sensation, or reflex changes within the same section within several minutes. Okay, after I take my baselines, right? Now I have my baselines. Now, based on the subjective exam and what I've seen on those baselines, meaning what's the range of motion like, I have to make a decision, right? So we have to we got to pick a direction, right? Is this someone with low back pain that actually, has more pain with sitting in a chair, sitting at work, sitting in a car, right? And they actually have relief when they are walking, right? Walking is guaranteed to make them feel better. So I have to make an educated guess. What direction do I need to move this patient, or at least start to, right? And that's where we get into these loading strategies, right? So with MDT, we start putting this patient through repeated flexion or extension, right? For that example I gave before, that patient that hates to sit, has more pain sitting is radiating pain down the legs, and they love walking, well, most likely, if you look at that infographic, it's the image on the right side of the screen, I might be looking at probably picture A, where they're either just laying flat on their stomach or up on their elbows. But as soon as I can, I want to see what end range extension looks like, right? Like picture B. I want to see what that cobra, or that repeated extension in line, that cobra pose, what effect that has on their pain, right? And McKenzie, in the McKenzie world, we always say end range is where the magic happens. So what does that mean? It means when you start bringing a joint, any joint, whether it's an elbow or a finger or a knee or a hip, in this case, we're talking about a low back, a lumbar spine. When you start bringing those joints as far as they can go in one direction, you're going to start to get information out of that joint, better or worse, right? Like I said, I mean, at the beginning, it's just an educated guess. This person, I think, is going to respond well to bending backwards or extension, but you don't know until you do it. But end range is really where we get those answers. You play around with mid-range, right? Like, maybe up on your elbows or maybe just, sitting. You may get better, you may get worse, but when you start bringing joints to end range, you're going to get information, right? How do we know when to keep going, when to stop, right? What is guiding us, right? And it's really, with the McKenzie method, it really comes down to this traffic light guide. So if someone is doing a back bend or a cobra, like you saw on the previous slide, a full cobra, that yoga pose, right? I don't really care what they're feeling during that movement, right? As long as when they come back down to the table or the floor, wherever they're doing that exercise, as long as they can tell me that what they just didn't leave them feeling worse, I'm going to have them keep going. That's a yellow or green light, right? So as long as you can say after every single repetition of that exercise, whatever I'm having them do, that it didn't leave them feeling worse, that's a green light and we get to keep going, right? Pain gets better as you do these exercises. That's a no-brainer. You keep going. Pain worsens at the top of that press up, but then you come back down, no worse, yellow light, keep going. The only time we're going to stop, is when we hit a red light, right? And a red light isn't increased. A red light could be increased during the movement, but when they come back down, it stays increased, right? So if they had 3 out of 10 back pain before they did a press up, and now all of a sudden after the press up, just one, now it's up to like 4 or 5 out of 10 pain. That's a red light. We stop, right? And in this way, we sort of have this built-in safety mechanism of, how do I know? And I tell people this in life too, not even just the McKenzie method, is what you're doing leaving you feeling worse? Sure, does what it feels like during, I don't discount it, but what's more important to me is how you feel afterwards. How does it leave you afterwards, right? If you're worse, or the pain is traveling further down your leg or further away from your spine, that is a red light and we stop. So goals of directional preference in back pain. In simple terms, you make everything better. Make the pain better, make the range of motion better. Improve the frequency and intensity of pain. Shift the distribution of pain from the limbs to the central spine. This is a really important concept, and it's called centralization. And that picture there on the bottom of that slide really shows you what I'm talking about here. Let's say a patient walks in, and the patient I have in front of me has symptom presentation of that patient all the way on the left-hand side, where that dark line is basically their pain. So it's starting in the right side of their lower back, and the pain is running all the way down the back of their leg, all the way to their right foot, okay? Let's say I picked extension for this patient. I have them get on the table, and they start doing some press-ups or some cobras or some back bends, right? All of a sudden, the patient tells me that they're not feeling that pain in their foot anymore, right? And they do some more press ups, and now, you know what? Now they don't even feel it in their calf. It's just in there at the back of their leg and their back. They keep going, and all of a sudden, You get all the way to the right-hand side of that picture and you have pain that is just in the patient's back. That's called centralization. And outside of the pain just completely being gone, that is probably the best predictor of someone that's going to have really good outcomes, right? If you could centralize pain, that tells me that that is 100% or close to it. That's a direction you want to start moving this patient. That's a really good predictor of someone that's going to have a pretty good outcome. You know, the flip side of that is that patient that comes in, you know, with just the back pain, that picture on the right, you start moving them. Maybe you pick flexion. Maybe you start doing knees to chest, right? Bending this patient. And all of a sudden, the pain starts to travel further into the hamstring, down the leg, into the foot. That is called peripheralization of pain, and we do not want that. That means that that patient is moving in the wrong direction. So that should be avoided. Okay, just a brief overview here as far as the lower back. I'm talking about the lumbar spine. The lumbar spine are basically, it's 5 vertebral bodies over there pictured on the right. And in between each of those vertebral bodies, we have discs that aren't pictured there. But those spaces in there would be these nice kind of cushions, discs there for shock absorption basically in the spine. And that's in between each of those lumbar vertebrae. We also have 5 pairs of lumbar nerves, and they're coming from the spinal cord and in between the lumbar vertebrae. Imaging, MRIs and low back pain. You know, this is where it gets a little tricky in my world when I'm dealing with back pain on a pretty, you know, consistent basis. MRI is a fantastic tool. It's a non-invasive diagnostic tool that can be used to examine the lumbar spine and surrounding tissue, right? Here, indications for the lumbar MRI: trauma, failure to respond to conservative treatment, weakness in the extremities, history of cancer, fever, loss of bladder or bowel control. You know, my job as a physical therapist is to rule out sinister pathology. What does that mean? That means somebody that's sitting in front of me that doesn't have pain because of a mechanical issue. Is it cancer? Is it a spinal cord issue? Is it a fracture? I got to be able to, is there an infection? I have to be able to rule these things out. And an MRI is a great instrument in ruling these things out. However, when you're talking about, just generalized back pain, MRIs are, people are sent out for way too many MRIs, right? And it makes, I think it a lot of times it can create a lot of fear in patients, and we'll talk about why that is. Especially when patients just are complaining of just general back pain without leg symptoms, without any other red flags. And don't get me wrong, we're always ruling out red flags. Is there something here that's a medical emergency that's not mechanical for me as a physical therapist to treat? But for the majority of patients for lower back pain, they most likely are mechanical in nature, and there's no need to rush and get that MRI without the presence of some of these red flags that are signaling to me and to the referring physician sort of an emergency. And this slide is why sometimes it can be problematic as far as, sending for someone for an MRI early on in their treatment, right? When regarding non-specific lower back pain, imaging should be used conservatively, right? Imaging can be misleading with back pain being poorly associated with imaging outcomes. Believe it or not, imaging and pain don't correlate as well as you may think. And this might lead to excessive desire for surgical intervention, right? Hopefully the recent emphasis is to refer to PT early for the McKenzie method for mechanical diagnosis and treatment. Symptomatic response, which is what I go by, is kind of a better, more valid option for low back pain diagnosis and treatment, right? That was found by the study in 2018. And if we look at this this graphic over here on the page, and you can tell what I mean when I say that MRIs can be very misleading. This is a chart of basically 3,000 asymptomatic people. 3,000, these are MRIs of 3,000 asymptomatic. What does that mean? That means people that do not have back pain. They do not have back pain, and they're stuck, they stick them in an MRI machine, right? Patients anywhere from 20 years old to 90 years old, right? And these are the findings, right? So these are people, again, no pain, right? So what does the MRI show? Let's just pick, I'm turning 40 this year. So let's look at the 40-year-old age group here, right? People in their 40s, disc degeneration. 68% of people in their 40s are going to show of disc degeneration on MRI. These are not people with back pain. These are people without back pain, right? That they just sat in an MRI. 3,000 people, okay? If we scroll down, people in their 40s, 50% of 3,000 of them, right? 50% of people in their 40s on this study are going to show disc bulges on an MRI. Again, these are people without back pain. So I think it could be problematic. An MRI is a really good piece of the puzzle, but when you think about, the amount of abnormalities in the normal population that are on MRIs, I think conservative treatment first is the way to go, without any of those red flags that we kind of talked about, making sure that there's not any serious pathology here. But, you start showing patients with just general back pain, these findings on MRIs, and when you don't explain to them this chart, you think that there's something really, really wrong with you, and that's what's causing your pain. And it could be, but, some of these things are just normal degenerative changes that we all experience. And it's only until you get placed in an MRI that you find that out. Some of this stuff, like I like to say, is just wrinkles on the inside. Common causes for lower back pain, herniated discs, right? I see a ton of that stuff. It's the disc we talked about being that cushion in between the vertebrae. Sometimes the nucleus, or that little, the part in the middle, the little jelly in the middle of that donut, can extend past the membrane and extend out of the annulus. That's where it sort of herniates and can press on some nerves that are leaving. Disc lesions are common low back pain ailments. And a lot of these people can have a directional preference, right? I'd say predominantly for extension, maybe sometimes extension with a lateral movement or rotation. It all depends on the patient. It depends on their response to those movements. Lumbar spinal stenosis. It's an anatomical reduction of the lumbar spine canal size that can cause pressure on spinal cord or nerves that travel to muscles. Commonly caused by progressively degenerative process, osteoarthritis. This is that patient that we tend to think of as the older patient who typically has pain in their lower back traveling into the leg, gets worse with walking. The more they walk, the worse the symptoms get. When they sit, the pain almost immediately goes away, right? That's the typical spinal stenosis patient. And this study in 2016 found that 88% of those in the study displayed a directional preference. My guess would be that was probably primary for flexion-based exercises, but to be honest, some of them respond well to extension too. So you got to move the patient. You can't treat based on the image or whatever the diagnosis is. You have to move the patient, see what the effect of that movement is on the patient's symptoms, on all those baselines that we checked earlier. Some other common low back causes: spondylolisthesis, stress fractures in the vertebrae, common in young athletes, maybe gymnasts. I've seen that in. Spondylolisthesis is a forward slipping of one vertebral body forward on the other one, typically a low lumbar. But even these patients where you're really not supposed to be extending them, in theory, based on their x-ray or their MRI, I've seen people with spondylolisthesis respond positively, symptomatically, mechanically from extension. You move the patient and see what the effect is. This is a study, a review by May in 2018. Centralization and directional preference were key prognostic factors in individuals with low back pain. Directional preference was present in 26% of all spine patients with low back pain. These things got to be looked out for more often, right? Do they have a directional preference? Can you centralize their pain? And this, I think this was Audrey Long's study, 2004, 312 patients with either low back pain or sciatica, meaning that there's back and leg pain. 74%, 230 out of the 312 patients were found to have a directional preference, right? Just think about that. 74% of all those back patients had a direction that they needed to be moved. They were separated into 3 groups equally and randomly. The first group, the exercises were matching their directional preference, meaning they were going into the direction that we found was going to be beneficial. Group 2 actually had exercises that were going to move them into the opposite direction, right? So if I found that the patient was going to benefit from bending backwards, these people were all given the opposite, or like forward bending or knees to chest or child's pose exercises. And then the third group was just giving, non-directional, just, exercises, not mainly one way or the other. So the results of this study, significantly larger improvement in pain and medication use for those with exercises matching their directional preference, right? So think about that. Those patients that were moved in the direction that they were found on the initial evaluation was their directional preference, did significantly better, right? Relied less heavily on the painkillers, had much less pain than the people in the 2 other subgroups. And the least improvement for those with the exercises against their directional preference. So that's kind of interesting that, you move, let's say someone benefits from bending backwards, the directional preference is extension. You start giving them flexion-based exercises. Not only did they, they didn't get better, but they may also worsen. So that's something to take into account too. And I think that is it. So if you guys have any questions, I would field them now.
Thank you so much, Dr. Rosenberg, for your excellent presentation. I wanted to open up the field for any questions, or if Dr. Lopez, you had any comments you wanted to add.
Yeah, Dr. Rosenberg. So much, Dr. Rosenberg. Oba, go ahead.
Sorry, Dr. Lopez. So I was wondering, sorry.
No
I was
problem.
wondering, for directional preference, does that still apply to patients with like chronic pain?
Oh, 100%. Yeah. It applies to basically anyone in pain, and it applies to any joint in the body, right? The neck, wrist, your fingers, your knee, your ankle, you know, all of these joints can have a directional preference. It doesn't mean that they will. Not every patient with back pain, not every lower back patient is going to have a directional preference. But chronic pain, absolutely. Absolutely.
Thank you.
Yeah, anytime. Great question.
I have a
Well,
question
go
too.
ahead, Kira.
When you were talking about the traffic light, if somebody were to hit what you'd say were a red light, what are the next steps after that if they shouldn't continue with those exercises?
Great question. So when we hit a red light, that means that the patient worsened after the exercise, right? And or symptoms are now peripheralizing or traveling further away from the spine. If they hit a red light, it's time to change directions. Now, and again, I don't want to get into the nitty gritty of it, but it basically means that it's time to try a different direction or a different variation of that direction, right? Some people, you know, might need to do a back bend with their hips kind of shifted off to the side. Some people may need to lay down and do a back bend instead of, you know, doing a back bend and standing. But a red light means, for me, at that moment, the patient's body is telling us to stop. I mean, really, I mean, it literally is a stop sign. It is, you know, pain is the most kind of, how should I say this? You know, there's plenty of factors that I monitor, meaning range of motion, strength, all that. But pain is the most important because no one's coming into my office because they can only extend their spine 60% and not 100%. They're coming in because it hurts. So pain to me is the biggest sort of the biggest factor of like, when do we stop? We stop when that red light hits. Pain is worse or pain is peripheralizing. It's time to change directions or try that same direction, but maybe in a different start position.
Thank
Great
you.
question though, yeah.
I also had a question. Is there any other types of motions besides flexion and extension that can be used to assess directional preference?
In the lumbar, so in the lower back, yes, right? I mean, there's rotation, there's a side glide, right? I mean, really, it could be anything, right? I mean, like the McKenzie method, you know, has basically discovered a lot of patterns, you know, of directions that seem to work better than others for, you know, specific categories, right, that we would kind of classify people in. But really, for the back and neck, I mean, it's really any direction, but there are definitely certain directions that are more common, that are going to be helpful for more people. That's typically probably where I start, assuming their subjective, what they're telling me sort of lines up with that, right? I go with whatever the patient tells me. The patient has all the answers, you know. Sometimes you just have to sit and listen.
I also have a question. Would
Yeah.
you say the peripheralization of pain is more due to neurological issues or compensation potentially that's happening at lower limbs in order to address the lower back pain?
Okay. Good question. You know, it's hard to say specifically what you know, what's going on there. I would say I'm talking about, you know, I'm looking for changes in the moment, like literally at the time this person is doing that movement, what is happening in real time. Because when you hit on a directional preference, you can see changes within minutes. You can see pain change, and pain can travel. I'm not talking about, yes, it can change over the course of a couple of days or a couple of weeks, but within that session, I'm looking for the pain to change. I'm looking for it to move. So when I'm seeing, peripheralization, I tend to think it's more nerve stuff. It's more, neurological stuff that's happening. Is there something going on with that nerve root that direction is just making more sensitive or, inflamed? If you're getting that stuff down the leg, more tingling, more numbness, things like that. That's what I think about in that moment. I think what you're thinking of is like over time, if someone has like a right-sided pain, are they using their left side more? Maybe over like time, but I'm when a patient's on the treatment table and I'm seeing that happen in real time, I'm thinking it has more to do with, neuro stuff. Good question, though. Anyone else?
Great, thank you so much. I just want to point out a couple things. I did appreciate you commenting that imagery does not reflect pain source. And I think that's an important aspect for any current or aspiring person to be a clinical, who wants to be a clinical evaluator, healthcare provider. It's important to not be drawn by the imagery. Evaluating the patient is really more important for you as a clinical provider. And it's also important to really listen to the patient.
100%. I mean, listen, an MRI, like you and I both know, I mean, it is a great instrument and it's super sensitive. It's going to pick up everything. You're going to see everything. So I want to make sure that, it's a part of the picture, but not the whole picture, right? And we don't need, without, again, not to repeat myself over and over again, but, without those, red flags, those things that are really worrying us, especially if it's just back pain, let's treat this conservatively first, and then if conservative treatment fails, that's always an option. But I think a lot of times what happens is you start, giving those images super early on. And, number one, it could really scare the heck out of some patients and potentially even make them feel worse. I mean, there's a lot of stuff on pain science that we're not going to go into right now, but, that the messages we get from healthcare providers matter when we're talking about pain.
Yeah, on that note, that was the second point I wanted to bring up. I think suppression of pain, particularly with radiculopathies, variations of presentation, if you don't suppress that, you can never get through physical therapy or even attempt to try to treat with directional preference. And I think you can maybe comment on that. I think that's why it's so important that the patients, when they do finally get to you, they have well-controlled pain.
Yeah, I mean, 100%. You're right on the money with that. You gotta move people, and you just gotta see what happens with their symptoms, right? It kind of makes my job, it kind of simplifies in a lot of ways, but there's a lot more to go into it. But at the end of the day, you move someone and you see what effect that movement has on the patient, right? And the other thing that this sort of method does, is that, the McKenzie method, it's a lot of hands-off stuff, right? Especially with the back. So, you're developing the kind of self, efficacy, for that patient to empower them that they can get out of the pain themselves, right? Like my job at its core is to teach someone how to sort of fix themselves. And if I can do that, and teach them that traffic light, along with that, I've done a good job.
And one final point, obviously, this is going to be a little bit more of a little spin on the ball. What do you think is the lack of potential with directional preference in the neck as compared with the lower back? We know that it does really well with the lower back, but not so much with the neck region. Is it due to the lack of or the amount of flexibility in the neck?
I don't know. I've found a lot of success. I mean, you know, doing finding directional preferences for neck stuff. You know, in some ways, I almost in some ways I almost prefer it to low back in different instances, because the neck has so much range of so many different options available. You know, that might be why, you know, some people, you know, struggle to find that directional preference, where the lower back, yes, you know, it can rotate a little bit. It can, you know, it's got some lateral glide, some side bend to it, but primarily it flexes and extends, where the neck has so much freedom of movement. That might be why it might be a little bit trickier, but in a lot of ways, I kind of accept that challenge, because it just gives me, I think it gives me more options as a clinician. When something's not working, you know, I can try rotation, I can try side bend, I can try extension, I can try like there's so many different options available to me, that in a lot of ways, you know, I mean, listen, there's directional preference in back and neck, but the neck, there's a lot more, I think, opportunities to try different things.
Great. Thank you so much for that. I think it was important to bring up, obviously. I don't think the juniors really would have acknowledged that. But again, I appreciate your time, and it was a great talk.